Hey everyone, it's your host Sebastian with the Restoring Human Movement podcast. Thanks for joining the movement. This is your first time to the show. Welcome. You've missed a lot of great information from shoulders to hips to knees. I think the last one was sciatica. Some of them are solo podcasts, like the one that's gonna be today, and other ones are interviews with industry experts and people who can provide really good information that perhaps I can't. I'm gonna make this one on YouTube available as well. There's going to be a slideshow of information. And don't worry, YouTube people, I know a lot of you just want to see stretches and exercises. There will be mentions of those towards the end. And there's links in the description as well. For the podcast group out there, I will provide a link to the YouTube version of this, which may or may not come live at the same time. We release different YouTube and podcasts on different days. So I'm going to do my best to get those together as soon as humanly possible. So we're going to cover knee pain today, and I'm going to cover this from a few different thought processes today and a few different problems, because the hard thing first is to understand is that knee pain it encompasses a lot of different problems, and I'll cover the 4 diagnostic categories today, just general categories that you guys should be aware of. If you're not aware of them, it's sometimes very hard to understand what to do with your knee and how to treat it and manage it. And do you need surgery and injections and so on? And understanding the basic category that it's in can help you understand a little bit more about what to do with it. So in this one, we're going to cover what current research says about some types of knee pain, as well as some things that can and can't work and so on. Also, how knee pain happens, the 7 myths about knee pain that you may not be familiar with, and you may still be thinking that it's actually true. We're going to cover the 4 diagnostic categories, like I mentioned, and we're going to cover the 5 treatments or 5 stretches and exercises that actually do work, and that's going to be the YouTube link that I'm going to supply you guys with. It's in the description. And there's 5 simple prevention tools as well, prevention tips. Now, the first topic we're going to cover is knee osteoarthritis today and what some of the current research says about it. The first thing to realize about osteoarthritis of the knee is there are some preventable aspects to it, at least I believe. And this paper that I'm going to show you guys, which is in the slideshow, if you haven't seen it already, is from 2015, and it mentions a few things that are generally related to having an onset of osteoarthritis of the knee. Osteoarthritis of the knee, number one, we should cover it, that it does not always hurt. It can hurt, but it doesn't always hurt, and it doesn't happen overnight. Like there's things that are happening over the course of years to months, even decades. They are creating osteoarthritis in the knee and changing the severity of it, maybe in your case. And so osteoarthritis of the knee they say this is the leading cause of pain and disability, and it leads to a reduction of quality of life. Like you can't do certain things that you want to do. It hurts, and then you feel physically disabled, or you're clinically disabled, like you're not able to work or do certain things and so on. This was taken from a meta-analysis and systematic review. And so they included 46 papers, but they screened out over 6,000 papers, but they only included 46. And they found that knee pain, onset of knee pain, was related to being overweight or obese. By the way, it's important to note that there's different categories of being overweight or obese. It's the clinical category for BMI. So it's related to both. Also, another risk factor is being female. Who'd have thought, right? The other risk factor is previous knee injury. They thought that actually hand osteoarthritis was going to be related as well, but it was found to not, and actually smoking was not either. They found that new onset of knee pain was 5% related to previous injury, 25% roughly was related to being overweight or obese. So in this paper, they were talking about how can we help manage people with knee osteoarthritis if we know some of the risk factors. And so this is saying clinicians can use the identified risk factors to identify and manage patients at risk of developing an increase in knee pain. Obesity, I think this is one of the easiest takeaways today if you are catching on already. Obesity and being overweight puts more load on your knees. And so it's going to be related to knee pain. All right. If you have knee pain and you're overweight, one of the easiest things that you can do is attempt to lose weight. Okay. Losing weight is obviously, it's not going to be something we're going to focus on really diligently in this podcast, but generally speaking, It's a nutritional problem. It's an eating issue. Normally, people will lose weight because they are eating better versus exercising more. And the reason I'm bringing this up is because a lot of people with knee pain, because it's painful, knee osteoarthritis is painful. It creates disability and so on. How do you exercise to lose weight if you have knee pain? It's very hard. It's this vicious cycle. And so managing the intake of food is one of the most appropriate things you can probably do in this case. Now, the next paper we're going to cover is, can exercise help with knee pain with osteoarthritis? As we mentioned before, it would be nice to say we can just simply eat better and exercise, but it's very challenging sometimes to actually incorporate exercise when you have knee or joint pain. This is a paper from 2021. In this type of research, they pooled a bunch of different types of research and they interpreted it to figure out what are the most common themes surrounding exercise and osteoarthritis. And so they found that 44 of the trials indicated that exercise significantly reduced pain and improved physical function to a moderate degree immediately after treatment, while evidence from 13 studies revealed that exercise significantly improved quality of life immediately after treatment with small effect. In addition, 12 studies provided 2 months to 6 months post-treatment sustainability data, which showed significantly reduced knee pain, and 10 studies showed improved physical function. Now, the conclusion was that amongst people with knee osteoarthritis, land-based therapeutic exercise provides short-term benefit that is sustained for at least 2 to 6 months after cessation of formal treatment. Isn't that amazing? Exercise can make you feel better and make you function better for 2 to 6 months after you stopped. And I think here's the interesting part in this paper was that they said that there was a moderate degree of pain reduction and improved physical function immediately after treatment. Immediately, meaning the same session. Exercise, when programmed well and coached well, can really help. The next one is about osteoarthritis after a knee injury. As I mentioned before, in the prior paper, the first one that we discussed a little bit was that a past knee injury can oftentimes create things like osteoarthritis. And so in this one, it said the odds of developing knee osteoarthritis following an ACL injury are approximately 4 times higher compared to non-injured knee. A meniscal injury and a combined injury affecting both the ACL and meniscus are associated with 6 times higher odds when compared to a non-injured knee. So as a takeaway, when you have a knee injury, there is a higher probability, generally speaking, that you will have osteoarthritis of the knee. But the good news is as you go back one paper, you can see that exercise can help you with function, it can help you with pain, and it can help you with disability. So I think we need to relate a few things together here is that osteoarthritis, again, does not always hurt and does not always disable, but it can hurt and it can disable and it can limit how much enjoyment you get in your life and so on. And so usually management of it, I think immediately after the injury and realizing that rehabilitation and exercise, a good formal exercise program, being physically active and having good hygiene skills about your knees can really, really help with, I believe, decreasing the onset of osteoarthritis because there's something that happens after the knee injury that creates the osteoarthritis. Now, the last one I'll cover with research is patellar tendinopathy. This is one that a lot of you are going to be told that you have. Whether you've had an ACL or meniscus, then at some point you may be told you have a patellar tendinopathy. And it's not wrong. It's not wrong. But a lot of people who have this will just take months and months off, or they treat the area where the tendinopathy is located within the tendon, like the degenerative zone. And so what this tends to do is it creates months and months and months of deloading. Okay, there's a time and place for deloading and taking some rest, but as this paper shows in 2015, this says that the cornerstone of patellar tendon management and rehabilitation remains highly specific, and it includes progressive loading of the lower extremity kinetic chain, muscle tendon unit, and the tendon itself. And so you can take some time off, but if you are taking excessive time off by probably, I'm going to say excessive by 2 to 3 weeks, you are missing some very easy ones you can do. And we need to make sure that we do load patellar tendinopathies and tendinopathies in general as soon as humanly possible. Now, the mechanism of injury with general knee stuff is obviously there's trauma, but most of them are non-traumatic. A lot of them, even ACLs and meniscus with things like soccer, change of direction and jumping and landing and so on, a lot of them are non-traumatic injuries, but some of you will have traumatic injuries, and that's not anything that you know that you really could have prevented that I can think of. It's just someone slid tackled you, or you hit your knee on something, or you fell, or I know that my dog just bashed me in the side of the knee, and that's just what she did. Most of them are non-traumatic, all right? And most of them, they include repetitive stress on the knee structures, which creates the knee pain. A lot of times the dysfunction happens from above or below the region, i.e. the hip or the ankle foot region are not working well, which will subject the knee to repetitive stress in whatever structure ends up being your symptom generator. And so the meniscus can be a little irritated with rotational forces when that could be absorbed in the ankle foot region or can be absorbed in the hip. Now, I should probably back up a second because I know a lot of you with knee problems have probably said, well, I've done a hip mobility and it didn't help. Right. But if your hips are generally mobile and they're working well, you don't need more. And so you need to figure out the area which is the outlier. And some people tend to only work in one region because that's what they've told is going to be helpful. But really, maybe the foot and ankle is a better starting point. I tend to find that the hip is the easiest starting point for most people. Or you find an area between two areas where they have problems. Let's just say if you have knee pain and back pain, I'd say the hip is probably a really good starting point. Now, let's say you have foot or ankle pain and knee pain, then I think we probably start at the ankle, possibly. Or you've had a past ankle injury, ankle turns, fractures of the ankle. Maybe the ankle's a better starting point. If you had a past hip dislocation or a FAI or past injuries in the hip, whether they be traumatic or not, maybe the hip's a good starting point. So you kind of take like an overall view, like don't go too microscopic in the beginning when you're starting with a mechanism of injury and how to reverse engineer the process of a knee problem. Now, past injuries do tend to come back. As I mentioned before with the research, injuries will come back. And this happens with every single area of the body. The only way to predict future problem is identifying that you've had a past problem. And again, the first problem may be traumatic or it may not be. But if you've had problems over the years with your knee, generally you're probably going to have it again. And it's not a bad thing. And just, I think if you know ahead of time, if people know ahead of time what may come to be, they have a chance to intercept and decrease the probability. I tend to think that people have the complete control over how long their knee pain stays around, how fast it goes away, and how much time passes between knee flare-ups. I mean, you can choose for it to flare up every week, or you can choose to have it flare up once every 5 years. It's really dependent upon what you want. And this really comes down to how well your hygiene is of your body. Not like how you smell, but it's, do you treat your musculoskeletal system well? And do you have some general physical activity? And do you see anybody to help you out of the flare-ups when you have it? Because the longer you have it, the harder it becomes generally. Also, there's a mechanism of injury that tends to be pretty common is too much too soon, or the volume is too much, and that can be acute volume or acute workload or chronic workload. Acute workload is like, I haven't worked out all year, but it's January 1st and I'm going to do 30 million jumping jacks. That's acute workload issues. That's a volume issue. It's just too much too soon on the joint when a joint or the tendon or the muscle or the ligament or whatever of the knee is too much on the knee when you haven't subjected to anything in the past where it's not prepared. It's just basically it's not prepared. Chronic workload is too much over time. We see this a lot oftentimes with people who are training for a marathon in the beginning of the year. They pick up a program that's like a 16-week running marathon program or half marathon program. And the time to build up is not enough, especially if they don't have a good base. And so those are the general things that we tend to find in regards to the mechanism of injury. Now, here's some myths. The first one is don't let your knees pass your toes. I think this has more been debunked over the last few years, thank God, because this is something that is, I don't know who made this thing up. I really don't know. And it's so prevalent. Even people who come in who don't have knee pain, and we tell them, we do a physical exam when we're looking at them actually squat, and they stop sometimes. And it's like, what's stopping you from going lower? Well, if I go lower, my knee's going to pass my toes. Who the heck, who made this up? Now I'm sure there's a time and a place for your knees not passing your toes. I'm really sure there's a time and place. And I'm pretty sure it has to do with, are you in pain? But also it has to do with how much weight is on your back, right? If your knees pass your toes when you're back squatting or front squatting or doing some type of squat, you're probably going to take load away from your posterior chain or your heels, and you're going to shove it into your anterior chain of your knees. And so it's just going to work a lot at the knee. And so it's going to produce a lot of shear force, they say, at the knee with too much bend. But generally speaking, let's just say from a movement standpoint, because once you throw weight into the equation, like the whole thing changes, like conversation changes. There's certain movements you wouldn't do if you had 500 pounds on your back or 100 pounds on your back. While if you just have your body weight, you can certainly do them. Attempt to walk up and down stairs while not letting your knees pass your toes. It's literally impossible, completely impossible. So that is something that I think you guys should just write it off for now. Don't worry about your knees passing your toes. For some of you who are dealing with back pain and knee problems, this may be the easiest way to manage your problem than you ever thought possible. Just let your knees pass your toes every once in a while. Like, it doesn't have to be all the time. Just because I'm telling you to go to Vegas doesn't mean go to the beach, or don't go to Vegas. I'm not telling you to go to the beach. I'm not saying don't go one direction, so go the other. All right. I'm not saying pass your knees over your toes all the time, but don't stop it. Just allow it to happen, especially if you don't have any weight on your back. The second myth is knee pain is an inevitable part of aging. This is something I think that has come from the old age type of thing, runs in my family type of thing, the hereditary or just age-related aspect of it. I disagree. I've met so many people of various ages who have knee pain, while I've met people of various ages who don't have knee pain. I met people in their 80s and 90s who don't have any knee pain. And now is it they're the lucky ones? No, I think it's just they just happen to live their life well. They had good physical hygiene. I remember this one gentleman I talked to. He was an interesting guy, and I think he was about 85 or so. He was an older guy. And so he moved so well. He squatted well. He hip hinged well. He walked well. He was just in good physical condition. And I said, what's your secret? And he said, I go outside and I pick up the leaves every morning. I said, with a rake? He said, no, one by one. He physically bends over and picks up the leaves. He squats down and picks up the leaves. He uses his leg. All right. I've noticed people sometimes when they have past history of knee pain, or they just get older, sometimes they don't actually get on and off the floor. Even getting off the toilet or out of a wheelchair is sometimes really hard for them because their legs are weaker. And it's not because they're old, it's because they just haven't used them in a while. I mean, you don't use it, you lose it. I mean, I love to say that, that grandma's wrong on some things, but grandma's right on this one. You don't use it, you lose it. But I wish you listened to her own advice. If you don't get down on the floor, you're going to lose it. Your quads will get weaker, your leg will get weaker, and then it's harder to use it when you need it. All right. Now, with that being said, I know that some of you, when you get on the floor, like the thing is like, I don't know if I can get back up. Right. That is the exercise. You put a chair by you somewhere, get on the floor and attempt to get back up. You can get up any way that you want to. You can make it a knee over toe version. You can do that one where I know everyone kind of rolls on their belly and then pushes their hips to the air, and they kind of stiffen out their legs and use their hands to push themselves up into a standing position. That's okay at this point. That's actually a hip hinge. Those are useful ways to build, I think, a preventative type of model, especially if you notice now in your 40s and 50s, you don't get down and off the floor, just try it. 25 times a day is enough. You got kids or you got a dog, get up and down off the floor. It'll really help you. Myth number 3 is running can increase the risk of developing knee osteoarthritis. I don't know many ways to put this, but this is wrong. A lot of seasoned runners who are dedicated runners actually have less knee problems than people who don't run. Now, I'm not telling you to run, but I think where this roots out of is that people who don't run start to run and they end up having a too much too soon phenomena. And they go to their doctor and they say, my knee hurts from running. And they say, yeah, don't run. It's a spike of activity, but if you had, as I mentioned in the last myth, if you had a little bit more of expose it every once in a while to running, then I think you'll be okay. If you ran, half a mile every day, or if you walked half a mile or a mile or 2 miles every day, I think you'd be less susceptible to having knee pain when you start running. All right. But just like eating cake, eat a little bit every once in a while. Don't eat the whole cake. You're going to have a bellyache. Myth number 4, my scan shows exactly my scan will show exactly why I'm having knee pain. Yeah, this is so X-rays and MRIs and ultrasounds, all of them can be very, very helpful. And I'm not a naysayer and a hater on imaging whatsoever. I do love imaging. I think there's a time and place for it, but there's a time and place for it. It will not show how you use your knees. It will show osteoarthritis. It will show meniscal frays and meniscal tears. It'll show signs of, or actually, all these images will show ACLs and PCLs and MCLs and LCLs and tendinopathies. They'll show all this stuff. But is it the generator of your pain? No, not always. I remember I had this one girl that I saw when she was in college. She had a condition of her foot and ankle area, actually of her foot. And so I was mainly concerned of if she had a stress fracture in her bone. And that was the reason why I was taking an image. When we took a couple images, we saw that the stress fracture was not apparent. It wasn't. It was not there, and she eventually recovered from that pinpoint bone pain. But also on the image, there was all these tendinopathies and all these other findings on the X-ray. There was arthritis, this, and osis, that, and so on. On the X-ray and the MRI and the CT and so on. And so I asked her, I said, do you have any foot pain here or there? And she said, no. Over the course of the next 2-3 months, she ended up having it there. Now, was it that the findings on the imaging was dormant and it was going to at some point pop up? Well, I would take it the other way. It doesn't mean that you have to have pain. She was a very high level runner. She was running 100 miles a week. Like, she wasn't having any problems there, but her image will show that she has normal, I hate the words, wear and tear, but wear and tear doesn't always hurt. I have this old car. I have a really old car. And it's not like it was when it was new, but man, it runs. It's dependable. There's no problems with it. There's no leaks. It runs. Very dependable. And so think about the imaging kind of like that car. Dependable. And if you find these little dings, who cares? It's not really part of the picture. It just shows that you've had a life and you've used your body. Number 5, myths. A steroid injection will fix my knee pain. Well, so this actually helps out sometimes when there's swelling in the knee. And sometimes the injection will reduce that swelling and it'll make it so your knee can actually move better. But I would take this a different route. And I actually chose personally to do a steroid injection in my knee. I did Synvista injections as well. I was having some knee pain from some trauma onto the knee, and it was direct impact. And so the Synvist wasn't really working well. I did 3 shots of it. It's the lubricant type of thing. They say, oh, this is going to lubricate the joint. And I thought, hey, this is a good theory. I'm going to try this. And so I was still not able to bend my knee fully. It still felt like a balloon in there. I'd move my leg when I was in bed and my foot would get caught on the sheet and I'd feel like it's kind of tweaky as well. And so nothing really decreased that until I got the steroid injection. Now, the steroid injection over the course of about 2 days made it so I had full knee bend, which was fantastic. So I took the opportunity to actually rehabilitate my knee at that point because there's no physical limitations anymore. Now, generally what was causing the problem was probably still there, but I was looking to support it. I was looking to create some support system. As you mentioned in the second paper, we were talking about how exercise and therapeutic exercise, corrective exercises, and stretches can really help out with supporting the knee and helping out with what you're doing day to day, helps out with pain levels and so on. And so that's the approach I was taking. Now, a steroid injection, it won't fix your knee. It will just be a part of the puzzle if it's needed. So if you need to deswell the knee, by all means, you can do that. If it doesn't do it with simple rehabilitation and some exercises that actually can work out really well for decreasing the swelling of the knee. But I didn't know those at the time. I'll cover them a little later. But if you need to actually have something to deswell it, by all means, I haven't had to send anyone out this year for that, but I know there's a time and place. Number 6, all meniscus tears and ligament tears need surgery. No. If your knee is physically locked in a certain position, meaning you can't flex it, can't extend it, it will not move. It's like someone put duct tape and glue on your knee and you cannot physically move it, then probably, maybe. All right. There's people walking around all over the place with meniscal tears and ligaments that are frayed and have damage shown and so on. And go back into that number I talked about, the MRI and the X-ray and the CT and like ultrasound. Can they be helpful? Yes, they can. But also people sometimes fuss about these things. Meniscus are managed really, really well with exercise. Not just jumping jacks, but, a specific program, a specific exercise program and guidelines of what you can and can't do for a little bit of time until your knee is prepared, and then you can go further. Ligaments, the same thing. They just take a little bit longer. Both of these have really low vascularity in the structures themselves. I think in the NFL, they're saying, that accelerated ACL program that's ACL is a ligament, anterior cruciate ligament. They're saying about a year. Some people are saying that that's a little too quickly because the ligament is still healing itself. And so you have to give the body some support. You have to, if you get the right exercise and guidance and right coaching and good acknowledgement of what's safe and what's not safe for you, you can certainly do this without surgery. And it's advised. Surgery will not change how you're using your body. It will not change the fact that you had a current injury and then you may have a future one. But again, learning the skill sets of how to manage it and decrease the probability is, I think, where the money's at. Number 7, you have to push through knee pain to get rid of it. No pain, no gain, baby. Yeah, this is incorrect. So most exercises should not really hurt. There's only a few that may hurt a little bit the first few reps with things like pushing through movement a little bit, or even some of the tendinopathy exercises. But the tendinopathy exercises generally should produce a pain reduction effect later. Like, you shouldn't leave a rehabilitation program or a physical therapist's office or a chiropractor's office or a physiotherapist's office and say, I feel worse afterwards. If that's the case, you may have the wrong program or the wrong coaching. Now we're going to get into 4 diagnostic categories for knee pain. This is a good general way to look at it. I think if you look at it like this, it'll give you some insight into what is going on. All right, number 1, internal knee issues, external knee issues, referred to knee issues, which in this case, there's no local structural damage. And then number 4 is too much too soon, which is, again, no structural damage. Number 3 and 4 also have negative MRIs, generally negative MRIs, negative ultrasounds, negative X-rays, negative CTs, you name it, all negative, generally speaking, other than the things that are normal dings and stuff that is on your car because it's not a brand new car. Internal knee structures, you'll find things like types of osteoarthritis or types of arthritis like osteoarthritis, also ACLs, PCLs, meniscus, Baker's cyst, osteochondral defects, even infections I'd probably put in this category too. Although some of these things are more, they do need more urgent management. Like an infection, you're not going to exercise this thing away. Osteochondral defect, like there's a chunk of bone like in there that came from a donor site and it's just hanging out in there like floating around. Like that may need to be removed. Baker's cyst, I've seen these things get reduced with some of the simple exercises I'll talk about later. Meniscus, normally very simple unless it's locking into a certain position. ACLs, PCLs, like this is something that may be a little bit more surgically related. I know there's been things thrown around about non-surgical ACL, PCL. I think it depends upon what you're going to do with your life later. I certainly know people who didn't have them repaired, but they're very careful of their knee because there is laxity in there. And generally speaking, the laxity, I think, will be a proponent of osteoarthritis to come. Not to say they won't get it anyways, but the more movement in the knee, I think the more issues with the bone and body trying to stabilize the area over time. So these are internal knee structures. Again, some of them can be managed with a good rehabilitation program. Other ones can't. External knee issues. This is your tendonitis, tendinosis, tendinopathy, bursitis, jumper's knee, muscular tenderness, tears, muscle strains, and so on. Think about all these softer tissues would be outside or external of the knee. It's outside of the knee joint. And so these things are really, really manageable with therapeutic exercise. Sometimes they'll require things that will decrease the pain in order to go through the corrective exercises. But if you pick the right corrective exercises and loading patterns, correcting movement patterns, like a lot of times people don't need a pain management strategy, but sometimes they do. Pain management strategies that may work for these things is like your soft tissue work, your cupping, your needling, massage, things like that. But I think it's going to be important that everybody realizes that a knee is generally an issue that can be resolved or managed with physical activity. Anything that somebody does to you, like stretching you, mobilizing the joint, in my personal opinion, these things can help, but they're a smaller percentage of what you need to do. You need to do something that challenges and prepares the knee, stabilizes the knee, and offloads the knee, which I'll talk about later, which involves hip, ankle, foot, limb, and core. It requires all of it. Like your whole body is a core, that quarter unit, like is important. Then there's referred to knee issues, which is things like a hip referral. Some kids will have a problem with the femoral head, which is, I think, 12-year-olds or so. They'll report things like knee pain. They won't have any hip pain, but they'll report the knee pain, and it ends up they have something called a slip femoral capital epiphysis. Not a really fun thing to have. They might need surgical intervention for that. But this shows how the hip may refer to the knee. Also, there's spine referral. A spine referral pattern would be something like a L3, L4, maybe an L5, S1, depending upon where in the knee we're talking about. So there's certain sections of the low back which can refer into the region. And there's a nerve, which you look it up online, it's called the infrapatellar nerve it's a branch of the saphenous nerve, which comes right around, it sits right on top of the patellar tendon. So for some of you out there who are having patellar tendon pain, but your image is generally negative, this may be something where you're like, maybe there's more to it. The cool thing is, at least when it's referred to the knee, like a spine referral or a local nerve entrapment, like the infrapatellar nerve, the branch of the saphenous nerve, these things are way easier to manage, in my opinion. I think they are the easier ones to manage. They don't require surgery or injections or medications of any type. I think they respond really, really well. But when you have a hip referral, like if you have something of a hip referral to the knee, like the slip femoral capital epiphysis, or avascular necrosis of the femoral head or something like that, we might need to have an image of the knee just to make sure nothing's going on there. And that's going to be based upon the patient's presentation, their age, their gender, their activity level, and things like that. So that's why having someone on your medical staff who really understands knees and hips and ankles and the whole limb, the whole body, not just a knee specialist, is going to be really important. And then there's category 4, which is too much too soon. On the slideshow, I put the New Year's Eve workout, and I wrote down and I have another picture of the 6-month Couch to Marathon training program. How do we know the status or the physical state of somebody who's starting on the couch? I mean, there's I'm 5'7", 165. There's me, who I don't run marathons, but then there's also maybe a 5'7", 300-pound person. We already know obesity has something to do with knee pain. So is this the right thing to do with somebody? The New Year's Eve workout is push-ups, squats, jumping jacks, sit-ups, lunges, and so on. And so these, I'm not saying these are unsafe for people. Neither one of them. I'm not saying they're unsafe for people, but it comes down to, is it appropriate for your body at that time Do we need to slow things down? Do we need to set the goals a little bit more appropriately too? 6-month couch to a 5K training for someone who's 5'7", 300 pounds, may be more appropriate. And it's not that they won't ever get to a marathon. It's just they need more time. You guys need more time to build up some adaptation and tolerance within the joint, within the limb, within the body, so you can actually attain the goal that you want. I'd love to say everybody coming out of high school can graduate college as a valedictorian, like within 6 months, but it's not realistic. Now, if they want to graduate within 4 years as a valedictorian, I think this is more attainable. You see what I mean? Like there's a time frame which is going to be important. Like you need to make sure that your goals are appropriate for your time frame and your starting point. Now, some treatments that really, really work for us at Performance Place are, number one is McKenzie knee extension. It's really, really helpful. Some of these things are going to be things that you guys can YouTube and check out, but really, I think you can probably, it's best just to see somebody who can help you through that. I don't know how many people I know personally who I've sent a video to, because we have videos on all these things. And we have videos for our clients or our patients who we send to them as reminders of how to do it. The coaching on the exercises are not specific to the person, because the way we coach each person is different. Okay. The amount of range of motion we go through with each person is different. And the considerations of what's safe and what's not safe for the person is different. Now, the videos we send them are general because we're trying to send them to everybody as a reminder. I kind of have a saying where I think we've talked about doing these videos more intricately, coaching more specifically to each type of person. There's endless types of people, but the hard thing is now we have like 30 different videos of one exercise, which in my opinion, I think the person probably is going to recall really well if we coach them well. All that has to be done is they're refreshers. These videos are refreshers. So McKenzie knee extension, you can go on YouTube and look up a refresher exercise. But I think if you're attempting to get better, you might as well see somebody who knows what they're doing. Okay. The second thing is skin rolling. Both of these things, skin rolling is just grabbing the skin and rolling it. We have a video online on YouTube for it. It's one of our most popular videos. If you look up Performance Place and skin rolling of the knee, or just look up Performance Place and knee, you'll see that this video is super, super popular. And if you look in the comments, is actually the more important part. Read through, it's people saying, "Oh my gosh, I've had knee pain for 10 years and I did this and it's gone. Thanks." And then there's other people who say, "What kind of sorcery is this? I can't believe this is so stupid, but it worked," and so on. Though my point is that these two top things really, really work super well to reduce pain, but they don't restore function. I'm going to say it again. I paused dramatically, so hopefully you guys get that. They reduce pain, but they don't restore function. The problem is we go back into the early reference, we said that physical exercise, challenging the limb through the whole kinetics chain, which is the core, the pelvis, the hip, the quad, the calf, the foot, the ankle, all of it, literally the whole limb, is important. And that's what helps out to reduce pain and restoring function for months at a time. These two things don't do that. These things are ways to manage pain. And there's nothing wrong with that, but that is one part, which I'll talk about a little bit later. The third thing I really like people to do is force your hip to take the workload. Okay. We have a few exercises we'd like to do with this. Taking a hip dominant approach is a really easy way to do it. Something like a hip thruster, a banded glute bridge, even a regular glute bridge may work well. Or for those of you who are scared of going knees over toes, even going knees over toes can make so the hip has to work if you get all the way to the bottom without having any problems. So forcing your hips to take some of the workload can really, 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 really help. So number 4, core work. I think side planks is a good one to do with this. Side planks is I remember there was a paper I read years and years ago, which I cannot get the reference anymore just because it's been years since I read it and I didn't write it down, but you guys can certainly look it up if you want to. So I want to say it was about almost 400 female college runners. And so they surveyed them all and said, "What's going on?" And they did some core testing on them. They did frontal plane, which is kind of like a side plank. They did forward, backward, and so on. And so they tried to eliminate the hips and the pelvis as part of it because they wanted to see how the trunk really worked, what was related to something like a knee problem. And so they released them all, collected the data, and they said, look, come back if you ever have knee pain, unless it's traumatic. If it's traumatic, we don't want to see you back. And so they came back one by one, and what they found out was, I want to say it was about 90% of them had deficiency when they were first tested, and something like a side plank, a frontal plane resiliency. And so a side plank is a really, really easy way to reduce things like hip drop when you're running. It helps out to support the side of the hip, the glute med, the glute max a little bit. And so it helps out with stability in that plane of motion, which is really important. The fifth thing is a single leg patterning exercise or a single leg stance exercise. Now, some of you may be familiar with single leg RDLs. I'm not telling you to do that because there's a weight in your hand. And a lot of times when I bring up RDL or a single leg RDL, people just stiffen the heck out of their knee and they rotate about their hip like they're kind of like a flamingo. It should be almost like a skater. And we have a certain way of teaching it at Performance Place where we show people on a wall. This incorporates some of that side plank because we have them lean on the wall, and it's like they're holding up the wall, and then they go through a single leg patterning. Now, this comes down to, this is where the unique coaching comes into play. Some people don't need to be coached very much on this. They do really, really well with it. You have them reach forward like they're going to touch a like a foam roller in front of them, or like maybe a chair or a desk or further on the wall, and they just are moving like butter, and they feel their hip working well. They don't have any knee pain and so on. Like it really works well. Other people, they tend to take their foot off the ground and put all their weight onto the inner part of their foot because the inner leg is the one that's supporting. There's only one support leg. Other people will tend to squat down really excessively. Other people will stiffen their back up, like they don't want to round their back. They're afraid because they hurt their back in the past. So there's different ways where we may coach somebody through this. And again, this is important because specific coaching of those exercise programs are important. Now, I made a little note on this, is successful knee rehabilitation is about removing demand from the knee, but then also returning demand as soon as possible. So there's certain things that you will want to take away, possibly, if they're triggers for your problem. Like if putting the knee past the toe bothers your knee, then don't do it for a week, but then put it back. If you don't put it back, you'll end up having an unprepared knee. And so successful rehabilitation comes down to removing something and then putting it back if need be. All right. I know some of you have probably had things like low back pain before. Rounding your back, sitting like with bad posture was really probably not good. And so you put a lumbar support behind your back and all of a sudden things felt better. Then you felt better after a couple of weeks and you got rid of the lumbar support. Now you sit sloppy again, which is not a bad thing. It's just reintroducing of the round. All right. It's probably not the way I would pick to do it, but it essentially is what it is. Now, as I mentioned in one of the in the second paper, which I think is the most important one of all of them so far, is realizing how quickly something like an exercise can help you. I go to the optometrist every year, and every year she checks my eyesight, and she says, is A better or B better? And I say, well, B. And she says, okay, how about A and B now? And I say, A. And she says, A and B now. Well, A again. It's immediate. And so this same thing can happen if you pick the right exercises, coached the right way. It's a misconception I think a lot of people have about using exercise as a way to recover from something like knee problems and jumper's knee and osteoarthritis of the knee. Like they think it's going to take months to get stronger. It's not about strength. It's about giving your body a new movement pattern. It's about giving your body a new movement opportunity and finding a new way to do something. Okay. So with that being said, just realize that the strength is important. Endurance is important, but the way corrective exercises can be used, if done in a medicative approach, can make you feel better almost immediately. I mean, halfway better, maybe. Like what'd that paper say? For those of you on YouTube, you can go backwards and read that paper. There's references right there. It says immediate. Okay. And so I cannot stress that enough. If you're not having the results with having immediate, then you may need to find something a little bit better. Now, the way we manage knee pain at Performance Place, we use something called the MAP-A-LOAD framework. I've talked about this with things like sciatica and low back pain before, but it really carries over to different parts of the body too. And so I mentioned earlier that you can modify pain. MAP load is an acronym. There's MAP, and then L is load. M is going to be modified pain. A is going to be activate the support systems. P is pattern new movement habits, and 4 is load the limb. So M, modified pain. I mentioned number 1 and number 2, the Mackenzie knee extension and skin rolling are really, really great ways to modify pain, but they're not the whole picture. It's not the whole program. It's just part. It's a really important part, but it's only part. The next is we have to get the support systems back. And this is going to be coming with things like I mentioned a side plank is really, really easy one to do. Or I said hip function. So a glute bridge, maybe something like that. These are basic, really basic suggestions with it, but these are important. The hip and core are very, very important for the knee because we have to take load away from the knee. And this is activating the support systems of the knee. Then we get into P, which is patterning new movement habits. Previously, it may have hurt to run, and so we're repatterning in single leg stance on the wall with what I mentioned just previously. This is patterning movement, and sometimes new movement habits need coaching. That's just the fact of the matter. And then lastly, number 4 is going to be L, which is load the limb, which is what everybody's been waiting for, is get the quad and VMO working and the hamstring and the adductors and all that stuff. And again, that is important, but I really think the reason why some people have ongoing knee pain is because they're not taking the necessary precursor steps like M, A, and P. They just load the limb, and then they end up having a problem because it's too much too soon, and they end up having fallout and they get frustrated. And there is a way to there are ways to make it so you can reintroduce your activities again, but having reoccurrent flare-ups and problems over months to years is, I'm sure, it really, really wears on the mind, and it makes it so the body sometimes we'll call it an allergy against that activity, like it doesn't like it. You can get it back in, but sometimes it just has a disdain for it, so it's going to take it sometimes gets a little harder to put it back in. Now, the preventative model that I would suggest is walking daily, ideally barefoot if possible. If you can't walk outside barefoot because it's too cold where you're at, walk around barefoot in your house. Even walking barefoot on surfaces that have rocks and pebbles, and this is all good. Even if you found a little area where someone did desert landscaping around your house, walk in there. This may be one of the easiest things you can do to prevent ongoing knee pain. Number 2, let your knees go over your toes. We talked about this earlier. This helps out for a variety of different reasons. It helps out with the hip function, helps out with the core function, helps out with deloading the possible regions for referred pain there, and also gets strength in the entire limb. And if you don't have current knee pain, maybe going knees over your toes every once in a while can really, really help. Number 3, challenge your body weekly. This doesn't have to be like I'm throwing up on the floor because it's so hard challenge. It's just challenge your body a little bit. This can be some moderate weight training. It could be going on a hike. It can be something like holding a squat position for 30 seconds, which is hard for some people. Doing a wall sit. Do something challenging. If you're finding that time is an issue, remove one of any shows that you may be watching, or possibly one of your meals. Just make 2 of them and freeze it, and then eat it the next night. And then that will give you a little time that you can actually challenge your body a little bit. So a weekly challenge is important because once you challenge it again, when you have a goal of something you want to do, like you have a better floor, you have a better you have a better foundation to go off of versus starting from like a couch. Number 4 is squat and hip dominant exercises that are challenging. Do them, find them. I suggested a few of them. If you have a personal trainer, talk to them about that. If you have a strength coach, they should know these as well. If you have a chiropractor or a physical therapist, they may know these as well. It's important to note that not all people will know these, but just ask them and listen to how they say it. Joe, what do you think about what's a hip dominant exercise you think I could do based upon your history working with me? Well, in that case, maybe ask somebody else. But if they go right to it, you know what? You can do probably a bridge or you can probably just pick up something off the ground, or long jumps. Maybe more confidence the way they answer it, mainly because I want to make sure that you guys, I'm not talking bad about these other people, but the fact of the matter is, if you ask me about blood work, I really don't know. Like, I don't know much about a lot of things in life, but there's people who are really, really good at suggesting knee and hip dominant exercises that can really help you, that are specific to you and what you can do today, not just a generalized program. Number 5 is don't stress out about the knee structures, the things that you find on the image. If somebody's already told you, don't worry about it. All right, dings on the car, as you mentioned earlier. If it really works well, don't worry about it. The last thing we'll cover in the slides is actually general physical preparedness, or GPP, as wellness. General physical preparedness is being generally physically able. And this is important because you need to have a baseline. I have a friend who, he has a good saying. He says, I don't want to be a human liability, meaning if there's a tornado that hits the airport that he's in, he wants to be able to get out himself or save people, not that someone needs to save him. So his goal of life for physical activity is to be generally physically able. And so, again, this is not talking bad about people who have disabilities at all. But in regards to making yourself physically able, I think if you make this a goal, versus having like an aesthetic look or a six pack or muscles or a thin waistline or like things like that, like general physical preparedness is really an easy way to program in things that you should be doing, but also not extremely focus on the things that you can't do. The slide I have in here is over the course of 6 months, the amount of physical strength gain that people had. In this case, it was females over the course of 6 months, and you can see that they, went up. My point is not to show you the basic numbers of like you should be here. It's more that it takes time. Dan John, who's a strength coach, he has a good saying. He says that physical activity, strength, and things like that, like physical abilities, it's like a college education. It's built day in and day out, brick by brick. It's not like it's all of a sudden you snap your fingers and it's there. It's something you really need to make as a habit. And so I know somebody who their mother recently had a surgery on their ankle, and so the general physical preparedness is a problem with her, mainly because I know, although we acknowledge at this point that she can't use her ankle because it's in a cast, she can't get out of the wheelchair because her arms are not strong enough. She can't walk around or hop or use crutches. She can't use a walker because the other leg isn't strong enough. It doesn't have the physical ability. So let's just say if we scale this thing back, because I know that people sometimes know that they're going to have a surgery or have something performed, in a year. Your goal may be to make the rest of you physically able, so it can compensate in a good way for the one that you're going to lose for a little bit of time. So general physical preparedness is something that everybody, I think, should strive for, no matter if they have one leg or two, one arm or two arms. It doesn't matter. Gender doesn't matter. Age doesn't matter. It's just being able to move yourself about and perform general physical abilities, walking, standing for 10 minutes, getting yourself off of a toilet. Like, these are things that I think are attainable for any age group. And the reason why I'm bringing this up is because beyond when we're talking about things like knee treatments and so on, like, where do you go from there? Well, you can go back into trying to deadlift 500 pounds or, run a marathon, or perhaps general physical preparedness might be another goal. It's way less stressful to do it this way, and also it's a very attainable goal for most people. Now, for all of you who are looking for the link of the YouTube video where I cover some of my favorite exercises, I have it. It is in the it is going to be in the description for the podcast. If you're watching this on YouTube already, then I will supply it in the description of the video as well. Now, at any point, if you guys want to get in touch with me or with my office, we do have in-person and virtual services available. We coach people with knee stuff virtually all the time and don't have a big problem. We tend to refer people when appropriate, to locations. And as you mentioned, and as we mentioned in this podcast presentation already, there's certain things that we can identify, the things that we can't help you with, and we'll let you know immediately at that point in time. So reach out to us. We'd love to help you, or at least find someone in your area who can help you as well. Let's get everybody to feel better from knee pain and feel physically able again. I think that is something that we can all do and strive for, and we'll have a better life for it. So looking forward to hearing from you guys. You can always reach out to us at p2sportscare.com. Our phone number is 714-502-4243. Subscribe to the channel and podcast. We'll see you next time.